Okay. Hi, everyone. I am presenting today on congenital disorders of glycosylation, specifically the considerations for a neurologist. So the case for this presentation is a 32-year-old male with prior history of GTCs and stroke-like symptoms. He received TPA, who presented with 2 additional GTCs. His review systems was notable for several kind of systemic symptoms of intentional weight loss, poor concentration, cough, dyspepsia, nausea, vomiting, diarrhea. He does have a moderate drinking history that he reported. And in terms of his exam, it was overall normal. However, his gait was assessed with PT and showed slightly impaired balance. His labs on presentation were notable for mild macrocytic anemia, thrombocytopenia, and transaminitis with a AST predominant pattern. The rest of the values are listed here. So he was admitted to the general neurology service for further workup of these seizures. His course was complicated by altered mental status as well as thought to be hyperactive delirium. His workup included the following. He had an MRI brain, which showed diffuse cerebral volume loss for his age. He had prolonged EEG and LP with CSF studies that were unremarkable. GI was consulted for the transaminitis. A liver ultrasound showed hepatic steatosis. And of the multitude of studies that were sent, he came back positive with the carbohydrate deficient transferrin test. So this test looks at carbohydrate chains on transferrin. And so I have kind of here in this diagram, the most common type is this tetrasilo. You can have other variations as well, where you kind of run into problems just when you start losing the carbohydrate chains. And this is seen both in alcohol use disorder as well as in glycosylation disorders. So to understand better these disorders, it's important to take a step back into cellular biology. So glycosylation is a post-translational modification of proteins and lipids, and it leads to a plethora of glycan structures, which play major physiologic roles. And you can kind of see here all the different types of glycan structures, as well as their various roles listed. These roles include protein folding, stability, regulation, transport, and function. Glycan structures participate in cellular signaling and response to environmental stimuli. Several of the compelling examples that I saw was activation of the immune system with presentation of pathogen-associated molecular patterns, the engagement of hormone peptides with their receptors, delineation of ABO blood type, initiation of the coagulation cascade, and cellular migration during embryogenesis. So there are many different disorders under this category. The very first that was discovered is actually eye cell disease, which you may remember from the STEP setting. It's a lysosomal storage disease back in 1980. And since then, 700 genes have been found to be important for glycosylation. At the time of this study, 170 were found to lead to a disease phenotype. These disorders are largely autosomal recessive, and they have variable penetrance, as seen with twin studies. So listed on, kind of shown on this slide, is a diagram with all the possible ways that these disorders affect people. These disorders, they're biochemically and therefore clinically heterogeneous and usually affect multiple organ systems. They're highly variable in terms of their symptoms and severity. The neonatal and childhood presentations are typically the most severe, but advances in gene sequencing have allowed further acknowledgement of less severe presentations. So the majority have neurologic manifestations, and these include intellectual disability, cerebellar dysfunction, seizures, stroke-like symptoms, and peripheral neuropathy. Typically also they have hepatic, ophthalmologic, and immune involvement. And the brain MRI may show cerebellar hypoplasia. So in terms of testing, as this is becoming a better understood type of disorder, and there's we will see kind of the rare presentations with neurological manifestations, it's important to see who should be tested. And sort of based on the best guidelines I could find with Neurology Journal and Continuum is really any unexplained clinical presentation, and particularly those with multi-system effects, should be considered. And there's a couple different pathways for testing. The screening test is the carbohydrate deficient transferrin test we talked about earlier, but the Mayo Clinic has their own version of this test that also includes mass spectroscopy analysis of some other glycan structures. The problem with this test is that you can get false positives with chronic alcohol use. Sorry, one of the false positives is that, and one of the false negatives, you can also get a lot of false negatives because it's just not comprehensive. There's so many different variations and different glycan structures that can be affected, and you're really only getting the most common with this screening test. And so if you have a very high clinical suspicion, that would warrant further investigation. So for those of you who may find yourself in the position where you are interested in evaluating someone for a congenital disorder of glycosylation, the Mayo Clinic has a really helpful algorithm. And I'm not going to go through all of this, but you can find this online. There's some screening tests that you can initially send out. In the case of our patient, he ended up with his type 1 over here. And then the next step is usually either enzymatic analysis, as in this case, or next-gen sequencing. So in summary, glycosylation is incredibly important for the development of protein diversity and function. Errors in this process lead to variable and multisystemic phenotypes. And the common presenting symptoms are neurologic. And just to remember, testing is a multi-step process with both screening and confirmation. And then here are my references.
I mean, that was really wonderful. I hope the Mayo is going to offer a carbohydrate panel that we can start ordering. When we went over this case yesterday, I've never heard of that kind of Fahrenheit test, but maybe we should start ordering it in memory. I'm sure it's going to be more. I said this yesterday too, Bill. I'm sure it's going to be more useful than a serum base level we get all of it. So, my glasses. I have to read something. All right. So it's my honor to introduce Dr. William Powers. Dr. Powers joined our faculty several months ago, and we're thrilled to have him here. He got his MD from Cornell and then did 2 years of medicine at Duke. He then followed that up with neurology training at UCSF. Established his career at Washington University in St. Louis, where he rose to professor, and then moved to UNC 12 years ago and was the Houston Merit Professor and Chairman of the department for 10 years. He has 150 peer-reviewed publications, mostly in the area of carotid atherosclerosis and revascularization. He's led many anti-sponsored clinical trials. But the reason he's here is that he is also a fabulous teacher. He was the Teacher of the Year at Washington University 4 times and 7 times at UNC. He was also the 2008 Washington University Medical School Distinguished Service Teaching Award, and he also won the A.B. Baker AAN Award for teaching in 2021. So it's an honor to have Dr. Powers on our staff and teaching our residents. He could have easily retired after his stint at UNC, but he has, like many of our faculty, a true and real passion for teaching and is really excellent at it. And I hope that will be part of his legacy here with us. So I'm going to introduce Dr. Powers. I'm not even sure what his title is, but I'm sure it's going to be a great talk. So take it away.
Okay, thank you very much. Makes me sound like my background since the Middle East. So what I want to talk about today is diagnostic testing. And for those residents who have worked with me, who have more than on one occasion heard me say, well, why are you getting MRI? And that's what I'm going to talk about today. So this is a project that we did essentially last year when I was at UNC. Heitor was a Brazilian medical student who contacted me and said, I'd like to come and do some kind of research. Do you have
Morning.
it? I said, well, I've got this idea, and if you want to do it, that's fine, but you could do a lot of work and you could end up with none. And he said, well, okay, well, let's give it a shot. So why did we do this? So we waste, as physicians and as a medical care system, lots of money. And one of the places where we waste lots of money is with unnecessary medical imaging. And one can look at the rise of magnetic resonance imaging, and it is very obvious. Here is an estimate that somewhere in the $100, perhaps $1 billion range, we are wasting money on low value screening testing. The amount of MRIs done in this country, you can see, this is the US, people over age 65 and US people under age 65, has just gone up and up and up and up. And other than Germany, we do more MRIs per 100,000 population than any other Western developed country in any other in the world. So this is really impacts the care of patients with acute ischemic stroke. Between 1999 and 2008, costs for stroke care went up, with the diagnostic component increasing faster than anything else, and the use of MRI just skyrocketed. So here you see overall stroke costs. This is imaging, and you can see it goes steadily up faster than anything else. But this is really striking. Look at MRI. From around the turn of the century, less than half the people, and it's just gone steadily up and up and up. So about 60% of people get MRI for their stroke, and they don't get it instead of CT. They get it in addition to CT. And so it's an add-on. So there are possibly some good reasons for this. The information it gives you may tell you about stroke subtype, timing, location, and theoretically you could choose better treatments and the patients will do better. People have also suggested that if you show that bright white TWI lesion on the gray brain to patients, it reinforces the fact they've had a stroke and they'll then take their antihypertensive medication better. So this actually might lead to improvements in patient care. But most evaluations of medical imaging, and this applies to MRI, and especially MRI and stroke, just look at whether it makes doctors change their mind. Now, if doctors change their minds, that doesn't necessarily mean patients do better. It only means patients do better if they change their mind and the new treatment they try actually improves outcome as opposed to just seems to make sense. This is a classic paper on hierarchical models of diagnostic. That is, how are you supposed to tell whether it actually is good, is effective?
Oh, sorry, that was.
And what you'll, we're all set. All right.
Good.
So what you'll notice here is these are the two we actually use to judge the value of treatments. Now, we require treatments to actually improve outcome or reduced cost, with at least keeping outcome the same. Most of the diagnostic imaging, as I said, is sort of in sensitivity, specificity, and effective diagnosis. So the question we set out to answer was, in the patient with an acute ischemic stroke, does the addition of MRI actually improve patient outcome? And we selected a very specific group of patients, and these were patients who were admitted to the hospital with a diagnosis of acute ischemic stroke based on clinical presentation and an initial CT. So they came in, they had a clinical syndrome that looked like a stroke, they got a CT, the CT did not show a hemorrhage or anything else, and they were admitted with a diagnosis of acute ischemic stroke on that basis. And then they either went on to get an MRI or not. So the study design we used was a propensity score matched cohort and a non-inferiority study. For me, these were things that I didn't even realize existed 10 years ago. And they turned out to actually be very, very, very well suited to this particular project. And I'll give you some details about exactly how these experimental designs work. So what is propensity score matching? Well, propensity score matching is a technique you can use when you don't have a randomized controlled trial. And it's designed for observation databases. And it allows you to select from a large observational database matched groups to do away with any potential bias. It was originally designed to assess treatments. That is, if you have a whole bunch of people, say, a very large database, and you want to determine the effect of the treatment, some of the people get the treatment because of characteristics of their underlying disease. And so that would bias your outcome. And so what you want to do is be able to pick matched groups that are unbiased relative to what their prognosis would be and the choice of why they got the treatment.
So Bill, you'd say that rather than the old method of correcting for underlying conditions that after.
So yes, basically the other commonly done here thing is you do covariate adjustment. Right? Basically, covariate adjustment on all the things you care about. I'm not a statistician. My understanding of the problem with covariate adjustment is it actually, you have to model what each of the covariates do, and that usually involves linear assumptions, and it usually involves having sufficient data to accurately model covariates. So essentially what this allows you to do, and I'll show you how we did it, is you match them beforehand and not adjust afterwards. So you need a large sample size. You define the treatment and control, and then you have to select the covariates you're going to use for your propensity score. And the idea here is you select things that are prognostically important at baseline. And you also select baseline variables that lead the treatment to be done. So, for example, if you're dealing with some kind of treatment that has a high morbidity and mortality in older people, younger age would be a predictor of treatment. So you would have to account for that in matching your groups, because that also might be a prognostically important variable. You can't include variables that treatment will affect. You get the propensity score, which in itself is sort of a multivariate score. Use the propensity score to match the groups, and then you see if you actually came out with balanced groups. And if you did, then you go on and do the analysis. So what did we do? So we went back to the medical records at UNC. UNC has a Get With The Guidelines stroke database. So we had a list of all the people who were admitted with stroke. We picked a specific time to look. The reason we picked this, and it turns out that this turned out not to be important. On the stroke service at that time, we had a wide variation in the attending's attitudes to routine MRI. You had one attending who tended to get them a lot. Another attending who tended to get them not very much, and a whole spectrum in between. So we thought this would give us a good opportunity to be able to match patients, because that was really a decision not really based on patient characteristics, but more based on attending preference. So we used the medical record. The other thing we did, excuse me, is we wanted to get follow-up. So we looked at 1 year after discharge, and we looked at the medical record, which included care everywhere. And then the two really smart people I worked with had the idea that since we were going to look at stroke and death as an outcome, they just searched obituaries, online obituaries. And of course, that gave the person, they could identify the person by birthday usually. And then they actually could get the day of death to see if it occurred within 1 year after discharge. Amazingly enough, back to this, we were able to get 96% follow-up with just a combination of the medical record and the obituary research, which for those of you who are used to clinical trials, most clinical trials that actually have patients come back every 3 to 6 months don't do better than that. So, adults, as I said, they had an admission diagnosis of acute ischemic stroke based on a neurological evaluation and the initial CT had to be done before the MRI was performed. I went back and looked at every single one of these patients and looked at the time stamp on the resident's admission note, the time stamp on the MRI if they had one, looked at the resident's admission note to see if there was anything in there that suggested that the results of the MRI were known. So I can personally guarantee that these patients were all admitted before anybody knew what the MRI was. The exclusion criteria were essentially incomplete information. And that was the information that we were going to need at baseline to model the propensities. So, Hightower looked at 1,324 discharges and came up with 508 patients who met the eligibility criteria. I looked at all 508 patients to make sure that they did, and also looked at them for what their initial CT scan showed. And we ended up with 123 who had an MRI and 385 who didn't. And no surprise, they were very unbalanced by their baseline variables. And you can see here that, you know, the MRI ones, if you just look at p-values, were seen later, had less severe strokes, had different risk factors, and had many more of them actually had, fewer of them had CTs that showed acute changes and different treatments. So this would have been a terrible comparison to do just based on the initial data set. So we did our propensity score. We used those 26 baseline variables. We matched the patients, the MRI plus patients, the MRI minus patients, and it worked. So let me show you how this goes. So these are the propensity scores. Propensity scores range from 0 to 1. We were matching for probability of getting an MRI. So you can see that the CT only patients had much lower propensity scores than the MRI patients. But when we matched them, you actually can see that the distribution of propensity scores is very similar because we picked those CT only patients who matched the MRI patients and essentially discarded all the CT only patients who had low propensity for getting an MRI. And that gave us a very well matched, a standardized mean difference of less than 0.1 is considered to be good balance. We ended up with a 0.111 and a 0.119, and everybody else was under 0.1. So this is a very well matched group now that we discarded 2/3 of the original CTO patients. So what about the subsequent MRIs? Well, this was really interesting. You know, as I said, we thought that it would just be attending dependent, but it turned out that most of the MRIs were actually not live-fixed. They were ordered by the ED physicians after the patient was admitted. They just went and did it anyway, or they were ordered by the Neuro-ICU in patients who got TPA just because that's what they do. Some were ordered by neurology residents on the stroke service. It's not necessarily clear why. If we looked at the 123 MRIs and looked at that little thing you fill out about reason for getting this study, for 111 of them, there was essentially nothing there. It either said stroke or left hemiparesis or aphasia, and for only a few was there actually a reason given, and you can see them here for actually wanting to get the specific reason for actually getting an MRI. So in the vast majority of cases, these were ordered apparently just because. So what do we use for endpoints? Well, we use two endpoints. The first one we used was status at hospital discharge, because we knew we could get that. The second one we used was stroke or death at 1 year, which we hoped to be able to get by chart review follow-up. We used the modified ranking. For those of you not familiar with it, essentially a modified ranking of 3 to 6 means not independent. And so that was our qualification endpoint, and we used stroke or death, which is a standard secondary prevention stroke study. So it's a non-inferiority margin. So a non-inferiority study is a study that you undertake to show that two treatments usually are, one is not inferior to the other. And what you basically say is, I'm willing to have a difference between the two of a certain amount that's small, and say, okay, I'll accept anything within that difference as being non-inferior. So how do you decide that non-inferiority margin? Well, there actually are, there's no standard way to do this. What we did was we decided we would look at 3 studies that designated what's called a minimally important clinical difference. So for non-inferiority studies, as I said, the minimally important clinical difference is what has to be less than that. All the two study non-inferior to the other. For superiority trials, when you do your sample size and power calculation, you set it up so as to not miss a minimally important. So you say, okay, I want to compare treatment A to treatment B to see which one's better. But I wanted to, if the trial comes out neutral, I want to be able to say, oh, well, I've excluded the fact that A is no more than 30%, 20%, 5% better than B. Okay. So we went back to the literature, and we found 2 non-inferiority trials. They used the same endpoint we did. They used it at 3 months. We used it at hospital discharge. We took the average of those 2 trials, which set non-inferiority margins of 5% or 10%, and split the difference. So our non-inferiority margin for hospital discharge was -7.5%. We found 2 randomized trials of secondary stroke prevention that used reductions of 25% or 30% as minimally important clinical benefit, and we split the difference there. So how does this work? It's really very rigorous. So you set your non-inferiority margin. And then you look at the 95% confidence bounds of the difference between the two groups. And the lower bound of the 95% confidence bound, that is the lower bound of the study you're trying to study is worse, has to be above the non-inferiority margin. That equates to level 0.25, because it's the two tails of the 95% confidence bounds, 0.025 down here and 0.025 up here. So what you're basically saying is I have a 97.5% probability that the difference between the two of these is not below the non-inferiority, not worse than what I'm willing to accept. Okay, so what did we find? So for death or dependence at discharge, that's a modified ranking of 3 to 6. We found that there was no difference between the two groups, statistically significant difference. If we look at the absolute difference and the 95% confidence bounds of the absolute difference, they went from minus 6.7%, that would be CT only worse, to plus 18.1%, that would be CT only better. And that met our confidence bound, which was minus 7.5%, and the lower limit was minus 6.7%. So by our non-inferiority margins that we selected, we could say that CT only was not inferior to CT plus MRI. So of those 123 patients in each group, 7 died in the MR group and 4 died in the MR minus group, leaving us potential for follow-up 116 and 119. We got follow-up data on all but 10. So we had a 96% follow-up rate for stroke or death. And here's what we found. Again, no statistically significant difference between the two groups. But when we look at the relative risk, the MRI group minus group, the CT only group actually did better, had fewer patients who died or had strokes. And if we look at the limits of the 95% confidence bound, the lower limit was 0.84, our non-inferiority margin was 0.725. So again, by this margin, CT only was non-inferior to MRI. So has anybody else ever done anything similar? Well, the answer is yes. So this study back in 2013 looked at a large number of patients, and here they did the covariate adjustment, not the propensity score matching. And they adjusted age, admission, NIH stroke scale, coronary artery disease, and atrial fibrillation. And then they looked to see if there was any imaging strategy that actually correlated with outcome at 1 year. And they actually found out that the only thing that correlated with outcome at 1 year was patients got CT angiography. That CT, MRI, MRA, echo, TCD were not associated with clinical outcome. So they concluded that maybe imaging strategies actually don't correlate with how patients do. This study was a bit different. This was a study from the National Inpatient Sample, and they looked at patients who received MRI or who didn't during their hospitalization. They adjusted for age, socioeconomic status, care setting, and comorbidities. What's missing here is anything about stroke severity. They actually found that the people who got MRI actually had a lower mortality. If you compare their data to our data were pretty similar on the mortality of people who didn't get MRI. They found that the people who did had much lower mortality, But as I said, they really could not adjust for stroke severity, and stroke severity, of course, is the most important predictor of inpatient mortality. We've talked about, actually Brendan and I talked about this last week. When you have two studies that give different results, you should look at the quality of the studies to decide which one has better quality. I will admit that I'm biased, but I think our adjustment is better than theirs for determining the factors that might lead to in-hospital death. So, this is a good study. Well, it had a lot of strengths. This was real world data. We used an electronic medical record system. Like I said, I was amazed we got 96% follow-up. I thought that was just a fishing expedition. We might end up with 50% if we have worthless data, but we did. The propensity score matching gave us well-matched groups for those variables we looked at. We matched all of the MRI plus patients. We had very good follow-up. And the endpoints that we report, I think, are very important clinical endpoints. Their disability and stroke, current stroke and death. They're important stuff, not discharged on dual antiplatelets versus discharged on a single antiplatelet. These are the real things that we try to fix. Is it a perfect study? By no means. It has significant limitations. We only looked at this very specific question of if you got a diagnosis based on a clinical presentation in CT, was adding MRI useful? There are plenty of other situations where initial imaging, if you're going to go to thrombectomy, TIAs we didn't do. Question, is this a stroke or not? And of course the awake strokes, which if you look at the Wake Up trial required MRI. This applies to tertiary centers where there is an in-house neurology resident seeing the patient, making the initial diagnosis. It doesn't apply to other situations. Few underwent endovascular treatment. Propensity score matching is good. But the problem is if there are unmeasured covariates that are important, as with all non-randomized trials, if they are prognostically important and unmeasured, that may be a flaw. This wasn't completely blinded. Obviously, going back to the chart to see who lived and who died and the follow-up, you would come upon who had an MRI or not. So we could blind the follow-up to essentially the treatment assignation. And we couldn't really address whether people were happier by having an increase, I shouldn't say increase, certainly by having a picture to see. So should we be surprised? I mean, should we really be surprised that adding MRI to CT didn't seem to make much of a difference? So this is a partial list of randomized controlled trials of ischemic stroke treatment that did not require MRI. And with about 2 exceptions, this is every randomized controlled trial of stroke treatment that our current treatment decisions are based on. Did not require MRI to decide whether someone was eligible. And so the results of these trials reasonably apply to people who fit the eligibility criteria based on CT. And you can see, for those of you who might not know these, the original TPA trial, ECAS-3, all the under 8-hour thrombectomy studies, these 2 thrombectomy studies, the dual antiplatelet studies, the novel antiplatelet studies, Chinese aspirin study, international stroke trial, all of the heparin trials that showed that heparin didn't work, and all of these secondary trials, atrial fibrillation, anticoagulation, intracranial stenosis, all of the aspirin trials from the 70s, 80s, and 90s, clopidogrel, on and on and on and on, endarterectomy, ECIC bypass, stenting, statins. So most of what we do is not based on having data from MRI. What about guidelines? So in the recent guidelines for early management of acute ischemic stroke, there is one place where MRI is specified as needed, and that's for patients with wake-up stroke. In the entire guidelines, there's one. In the secondary prevention guidelines that came out last year, there is one place where MRI is specified. And that doesn't even make any sense because it's in this table of what we should do evaluating somebody for PFO closure. And they specify you should get an MRI. But if you look at the PFO closure trials, they didn't require MRI. So why they decided to do that, I'm not quite sure, but that's the only place in this entire guideline that they actually specified. So what can we conclude? So in this study, we used propensity scoring to match the patient. We found that the diagnostic imaging strategy of initial CT alone was not inferior to initial CT plus MRI with regard to clinical outcomes and discharge and enrollment. We should not assume that MRI adds value to the care of patients with acute ischemic stroke. Who needs it? Who benefits from it? We really need more data to figure out. But in fact, this is actually backwards, right? It shouldn't be that we're showing that CT only is not inferior to MRI. Really, we should be showing that MRI is superior to CT only because it costs more money. Unfortunately, that genie is out of the bottle and will not go back in. This work was published in JAMA Network Open in July. If any of you are interested in reading the publication and getting details about it. That's the 10th half of it.
So anybody with questions out there on the internet, enter them in chat, we'll call on you. Any questions from the audience?
I had a question about the CTA changing the outcomes at 1 year. Is that because it guided treatment decisions for like?
So the question was, in that one study that I quoted, they found that CTA was associated with treatment outcomes at 1 year. So my guess would be that study was published in 2013 and actually was from obviously years before that. So that was really before the thrombectomy era. I would guess, if I had to hazard a guess, but I don't know, that may have to do with CTA of the neck for carotid endarterectomy. That, if I had to hazard a guess, I don't know that that's the case.
Did you look at, or do you know if others look at whether the MRI has changed management decisions? Doesn't look like it changed the outcomes. But
so we didn't look at whether the MRI changed management decision because people have actually looked at that, and there's 3 or 4 papers, and some say yes and some say no. But the usual management decision And you do the CT to rule out hemorrhage. And that's the group we're talking about. That's, I would say, I don't have actual numbers, but I would say that is the majority of patients who present to a hospital emergency room with symptoms that you can, as I like to tell, my grandmother can diagnose a stroke if it's straightforward. We're talking about the straightforward ones.
Is your grandmother still alive?
No, she's not. But she actually did her medical training before. You can even diagnose a stroke without a CT.
But, I mean, just from going to morning report on Tuesday, it seems to me that the latter, the unclear stroke-like symptoms are more common than the obvious stroke.
I might say that's what gets presented.
Or,
I mean, I don't know. I mean, most of the patients that I see, it's like it's a stroke. It's not difficult to figure out.
all right, let me ask you another question. Now we have you up there. Any questions from the audience? All right.
Just one more, did you happen to take it a step further and look at costs of the hospitalization for delayed discharge, waiting on the MRI?
So we look at length of stay. My recollection, I have this buried away somewhere, is there was no significant difference in length of stay. Now, the cost is, so we should talk about cost for just a minute because it's tricky. So for Medicare, stroke is under a DRG, which means the hospital gets paid a flat fee for everybody with a stroke, unless they exceed a certain threshold, and then they can get paid extra. So, and I don't know how things are here, but at other institutions I've been at, stroke can come in slightly in the black if you are parsimonious with the number of diagnostic tests you do. If you are not, it becomes a money loser for us. Now, you could say, I don't care whether the hospital loses money or makes money, that's a legitimate point of view. But sooner or later, somebody pays. Medicare premiums, other premiums, however it works, sooner or later, somebody's paying for unnecessary diagnostic testing. Might not be that patient at that time, but somebody's paying.
So we have a question from Carolyn Pizzoli. Carolyn, can you,
Certainly.
I'll read it if you don't get it.
Can you hear me okay?
So she's talking, but I don't think this is.
It should have been,
Probably the choice.
yeah,
Can you hear me?
it should be on Crestron. Crestron is, okay.
Carolyn, can you try reading it again?
Can you hear me?
Here.
Hello?
Yeah, I can hear you on my phone. I can't hear you in the audio.
So thank you. Can you just
No,
for me?
Let's see if I can. Okay, Karen, I'll just read it because we can't hear you. Okay, so the question is, stroke in the young, consideration of vasculitis or vasculopathy rather than a pure atherosclerotic painful.
I think my point was there's
So
some,
I could give a 1 hour lecture on stroke in the young. How it's very, very, very much, I think, over tested. But yes, there are certain situations. But I don't know that MRI is necessarily going to help you in vasculitis versus vasculopathy. Are you talking about vessel imaging? Whereas this was, really standard parenchymal imaging. We did not look at, plus MRA or minus MRA. We just looked at what they had some kind of.
Right, another question, Carolyn, what are some other groups besides those discussed that need an MRI in an acute setting?
So the answer is, I don't know who needs an MRI in an acute setting. Because other than the clinical trial, wake up trial, which actually requires it. I don't know of any studies that actually correlate MRI in the acute setting with outcome in a particular.
Okay, let me, we don't have another question. So there is a desire to know what happened, right? I mean, in the old days, you'd have to wait till your autopsy to figure out exactly what happened, so you can learn from it. Is that a valid reason for MRI?
So that's a very interesting question. So as an educational institution, I think that in certain particular cases, it can be useful to know. We should recognize and be very transparent about that this MRI is for us, not for the patient. And you know, that's certainly reasonable. But I don't know that that is a reason to do it in everyone.
Anyway, thank you, Bill. All right, anyone with other questions for Dr. Howard from down here? No, let's see what we did. I think we did something off.